for the World Cancer webinar from Niramai, where we have excellent speakers lined up. Of course, none other than Dr. Harsh Mahajan, who's Padmashree, our favorite, very well-known radiologist, who will be giving the keynote at 4:30, followed by a knowledge session by Dr. Bhavna Dev, where she did an excellent tutorial-style description of vacuum-assisted biopsy. I requested her to come in. And we would then have best practice sharing on cancer screening programs by eminent NGOs from KPED, Mridu Gupta, ALVL Foundation, Ms. Tansi, as well as Dr. Suranjeen, who's very well known from Japago. Before that, just sort of to open this and give the context, let me stop the waiting. Can you remove the waiting room? Enable waiting room. Yeah. You can admit everyone now, Shiva. Yeah.
Sure.
So, yeah. So just a bit of context again for those who are seeing this for the first time. World Cancer Day is celebrated around the world on 4th February. Celebration is probably a misnomer, but basically it's a day where all of us get reminded of the responsibilities that each one of us have towards making the world hopefully a cancer-free world. The theme for last year and this year has been closing the care gap, where we're trying to give equitable healthcare irrespective of the economic differences, geographic differences, gender differences, age differences. So how can we make them all realize, enable early detection, get them the treatment at the right time, and obviously save many, many lives. The cancer facts right from the WHO website really says this very, very clearly, why this is very, very important for us to take care of. 10 million deaths every year. In 2022 is also a very similar number. It is the top cancer or rather top cause of death across the world, actually. Most common cancers being breast, lung, colon, rectum, prostate. Major cause of cancer, 33% of that, 1/3 of the cancers are caused due to use of tobacco, not exercising well, and having a high body mass index, alcohol consumption, food, specifically low fruit and vegetables. And it's known that about 30% of cancers are caused due to some of the infections, which are HPV and hepatitis. If you have not taken the vaccine, you should. But the most important point is that many cancers can be cured if detected early. And that's what we're going to sort of see more later today. What are the different ways of detecting early cancer, different imaging techniques that Dr. Herser is going to talk about. Some of the facts about the cancer in terms of incidences. This is the almost latest number coming in, this 2022 number from the WHO, where we now see 19 million, close to 20 million cases of incidences of cancer around the world, 20 million, and almost 10 million cases of deaths happening every year. This is again 2022 number, where across both genders, lung is about 2 million, and then we have colorectal, liver, and breast being 670,000 deaths. If you look at the mortality rates in the male segment, lungs and liver stand out as the top cancers, whereas in female, breast remains the top cancer with 665,000 women who died in 2022, followed by lung. Of course, breast cancer continues to be the top cancer. And in fact, Asia will see 50% of them, has seen 50% of mortality. And so we need to do something about the early detection. And it is the top cancer is almost 159 countries as well at a country level. So as you are aware, Niramai is on a mission to develop innovative AI-driven diagnostic tools, particularly now looking at breast cancer as the main cancer that we want to detect early and save many, many lives. And as many of you are aware, Nirama has developed this new method of detecting breast cancer called thermolytics, which can detect cancer much before a symptom appears and works for women of all age groups with no radiation and in an affordable and accessible manner. In also a very, very good patient experience where, nobody sees or touches the person during the test. And for this, we have developed a new method of detecting breast cancer using artificial intelligence over thermal scan. I guess some of this will be referred to in the overall program today. Having said that, this thermolytic software is a made in India software-based medical device that has resulted in 33 granted patents around the world. The 34th is coming up next month. And this is a proud moment where Indian innovation has now also been accepted in both Europe and US and of course many other countries, and multiple clinically validated publication results in top publications have been published, and happy to sort of share more details of this for those interested. On the ground as well, we have completed more than 170,000 women who have been benefited from this test, with hundreds of hospitals using it and thousands of camps being done. Today, we are in 8 countries, and as we speak, we are expanding to more number of countries. A lot of our customers are listed here, including corporate customers, Googles of the world, as well as a lot of outreach partners who are helping us do this free of cost to the rural areas, and many, many hospitals, including Narayana, Apollo, HCG, who have started adopting and actually already impacted thousands of people in their own hospitals as well. Talking about the closing the care gap, we have conducted several rural camps thanks to our sponsors and our own Niramai sponsorship. We've been able to impact, rural women, women in urban area who are underprivileged as well, in 26 states today, including Punjab, which is where we have actually impacted 15 districts already. You can see many, many of these. We're very happy and thankful to many of our partners, including Karnataka Cancer Society, who has helped us take this to corners of Karnataka as well. So I know I have like 5 minutes before we give the main stage to the invited speakers, but here is a call to action from Niramai. All of us, we are on the path to help women detect cancer early. First and foremost, please, please, please do self-test examination. There are several videos available on how we should be doing it, and also even Niramai has actually released a video as to how to do this. Secondly, annual or biannual breast cancer screening test. Don't wait for symptoms. Even before a symptom appears, you need to catch it. And that you can do, of course, with thermolytics. And there are other very, very, traditional tests, which Dr. Mahajan sir is going to talk about, including mammography, ultrasound, MRI. So please take, the test that your physician prescribes, or if, of course, thermolytics can be taken as well, annual or biannual, depending on your age group. These 2 things are mandatory. Of course, you also have to know what are the symptoms of breast abnormalities or breast cancer, including lump. You feel a lump or you feel pain at a particular area in your breast, or you find some changes on the skin or size of the skin, or any kind of a discharge coming out of the nipple. Any of these symptoms you see, immediately go to a gynecologist or a physician. And again, even though there is no symptom, you need to do the regular breast screening in a preventative manner. I would also like to sort of announce this new app that has been released by Cancer Protect Foundation. In fact, we are part of the Breast Cancer Hub, where all of the people who are working in breast cancer screening come together. And today they released this app called Can Protect app, and it's a free app for people who want to download and perform monthly self-examination and look for suspicious signs and things like that. Please talk about this app and talk about the need for screening to your people around you, at least 5 women, I would say. Talk about breast health and why it's important. Being on this mission, it is our duty as Niramai to create platforms to spread awareness about cancer, not just breast cancer, but also several other types of cancers. I also want to mention that Can Protect Foundation is led by Dr. Sumita Prabhakar from Dehradun. She's also one of our partners who's using Nirmai test. So that said, while all of us get ready to, eagerly listen to the eagerly awaited talk by Dr. Harsh Mahajan, followed by Dr. Bhavna Dev's knowledge session and the panel discussion, I request all of you to go on mute if you have not pressed the mute button. If you have any questions, you can raise hands in the reactions tab below. Then at the end of the talk, we will take the questions for each of the speakers. And at the end of the whole session, we will have some discussions period where you could share your thoughts or personal experience. If you would like to, you can do so before we request Dr. Collison to come in and provide his closing remarks. If there are no more problems of getting on to this, I also request my colleagues Hemant and Shiva to mention whether we are live on YouTube going well, Facebook going well.
It is live on Facebook.
Okay, fine. YouTube, we will put it up later. Fine. So with this, I again invite you all to stay on till 6:15 to 6:30. Listen in. It's the audience is just assumed to be general audience. If you have any questions and some doubts on terminology, feel free to chat or raise your hand to ask questions orally, and we will unmute you. Now, with this, I am very, very happy to introduce Dr. Harsh Mahajan, sir. It is our great, great privilege to have him as a speaker and a keynote speaker on this program. As many of you are aware, he is Padmashree, India in 2002, Government of India awarded him the Padmashree. He is an eminent, very, very famous radiologist, not just in India. I go to RSNA every year in Chicago, and he is the center of stage for even there. Like, he's very, very well known. He represents almost in every international forum. Also, he represents India, and he's an eminent radiologist, and he's a pioneer in the field of MRI from India. He is the founder, chairman of Mahajan Imaging Labs. Many of you in Delhi would have gone there. He's also chairman of Caring Center for Advanced Imaging, Research and Imaging. Is also chairman of Neurosciences and Genomics in Sri Gangaram Hospital. Is member on the board of NABH, the body which gives recognition to hospitals to say they're good hospitals. Then he's also on the board of Health and Mental Health Committee of National Human Rights Commission, and advisor to several government committees and national groups. Earlier, he was a consultant to International Atomic Energy Agency in Austria, and also advisor to UPSC. And as per the education goes, he is a graduate from MAMC New Delhi and postgraduate from PGI Chandigarh. He has done his fellowship in MRI from MD Anderson Cancer Center. Apart from the Padmashree that Government of India has awarded him in 2002, he was the national president of IRIA, the Indian Radiological Imaging Association, in 2012, and president of Nat Health in 2021. Currently, he is the chairman of FICCI Health Services Committee. Again, I welcome Dr. Harsh, sir, to deliver the keynote, which we are all eagerly waiting for.
Thank you very much.
Request you, thank you, sir, and request you to please share your slides, sir.
Yeah, thank you. Yeah. Can you see my slide?
Yes, sir.
Great. Yes. Good afternoon, good evening. Thank you very much, Geeta, for putting the entire talk into perspective. And congratulations to Niramai, not only for organizing this, but also for doing yeoman service to women's health in the field of breast imaging, cancer, by bringing in this thermomammography device, which it appears is going to revolutionize the way screening is done. These are still early days. Wonderful to know that 35 patents are already granted and
Yes.
several more in the pipeline.
Right.
But I'm going to take you through what is the current state of art, and probably Niramai is going to be disrupting at some level this, or maybe augmenting it. That we will know as time goes by. And you've seen very nice images shown by Geeta of thermomammography. And let me just say what it is before venturing into my talk. Actually, cancers are supposed to have a higher temperature than normal tissue, and that holds true in the breast, where breast cancer tissue, and I'm putting it very bluntly, is warmer than other tissue. And using very fine thermal detectors, one is able to actually visualize the thermal energy coming from breast tissue, and where there is cancer, one is able to see that distinctly. And then what Niramai has developed is an artificial intelligence tool which is actually able to make sense of this huge amount of data that's coming in and be able to pinpoint the malignancy. What Where this is useful is that it's actually non-traumatic. There's no radiation involved. It's simple, and hence this can be the initial screening tool, where the idea is to pick up a malignancy. Idea of screening is to pick up a malignancy before actually one is able to feel it. And towards that end, this is going to do very well. And congratulations, it's completely indigenous, and that makes us all very proud. Now, screening mammography as it exists today, and we will talk about that. Uh, my slide is kind of stuck.
We can see the title slide.
Yeah, I know. I'm trying to advance and it's not happening.
Maybe you can press escape and share.
Yeah, I tried that.
Uh-oh.
Hang on, I'll just get out and then come back in.
Sure.
Just give me a sec. Yeah. Sorry about this. Okay.
Yeah.
So, screening mammography, and here right in the beginning, we need to know what is screening. Screening mammogram is an examination done in women who do not have any breast symptoms or signs. They don't have pain, they haven't felt a lump, they haven't felt nodularity. This is screening. We have to discriminate this from diagnostic mammogram, which is done in women who have clinical breast symptoms like a lump, or who have been called back after a screening mammogram because a screening mammogram showed something that was abnormal. So, screening where we don't feel anything, we don't have symptoms, and diagnostic mammogram where a lady feels a lump. I'm sorry, I don't know what's happening here.
If you would like to share the slides, I can share it for you, sir.
Yeah, should I email them to you?
Yeah. Okay. Email or WhatsApp also is fine.
Yeah. Sorry, I'm so sorry about this. It's never happened before.
Did you share full screen when you shared this, or
No, I didn't share full screen. Can you now see it?
yes, we can see.
Yeah. So let me play it in this mode only. So we've differentiated screening from diagnostic mammogram, and then screening mammography. What is the age and frequency in ladies who are at average risk? Now here we have to divide the entire population of women into two different parts. One is those who are at average risk, like any other woman, and the others are those who are at higher risk. Average risk women, and here we will see how it is done in different parts of the world. In US, they start at 40 years of age, and an annual, once a year screening mammogram is done, and this in the US is covered by insurance. In UK, on the other hand, they start at 50 years of age and they do once in 3 years. This actually everyone believes is not the right way of doing it because the gap is too much. But here in the UK, it is covered by NHS, it's absolutely free, and there is a huge resource constraint because of which they've chosen to start later in life than 40 years, in fact, at 50, and do it once in 3 years. Of course, if a lady were to feel any symptoms in the middle, they would do it earlier. In India, also we start at 40 years. We do know that most malignancies happen earlier, at a younger age in our country, and there is a choice between annual or once in 2 years. Generally, those at average risk in India undergo examination once in 2 years, and this by and large is not covered by insurance, so the lady is actually paying out of pocket. Now, who are the women who are at high risk for breast cancer? These are those who have a known genetic mutation or a syndrome which confers increased risk. So these are those where, already a test has been done, you know that there's a genetic mutation, and these are, tests which are called BRCA1, BRCA2 mutations, and these put people at much higher risk of breast cancer. Now, the classic case is of the Hollywood actress Angelina Jolie, who underwent these, genomic testing, and she was, as she herself said later, and I think she's done yeoman service to women's health and especially to breast cancer screening. She was at 80% higher risk of developing breast cancer, and so she decided actually to undergo bilateral mastectomy, and of course breast was reconstructed by surgery. And so, if there is already a known mutation that puts a lady at higher risk, also a lady who may not herself have undergone genetic testing but has a first degree relative with a BRCA mutation, then that also a lady will come into a high risk category, and the risk may be 20% or greater, lifetime risk for breast cancer. Then a first degree relative with breast cancer, if your mother, your sister has breast cancer, then you can start 10 years earlier than the youngest first degree relative was diagnosed with breast cancer. So suppose a lady's mother has been diagnosed with breast cancer at age 45, then this daughter of that lady can start doing her annual screening at 35 years of age. So 10 years before cancer was actually diagnosed in her mother or in her sister. Now, first, here again, there's a proviso: don't start before age of 30. Then, in those ladies who have a history of chest radiation, which has been received between the ages of 10 to 30, then we need to start screening 8 years after the radiation therapy, but not before age of 25. Then those with biopsy proven lobular neoplasia or atypical ductal hyperplasia, these the ladies are at higher risk of breast cancer and need to be very, very careful. Biopsy proven DCIS or ovarian cancer, we start at the time of diagnosis regardless of age. So these are women at high risk of breast cancer. And what is the screening mammography age and frequency in high risk women? In all instances, initial discussion should be done with your doctor, with the surgeon, the breast surgeon, or your gynecologist, or your family doctor. One must discuss this before you embark on the screening program. In the US, they start at 30 years of age with an annual X ray mammography. And in the last few years, MRI, which is more sensitive than an X ray mammography, has become standard of care. Especially younger ladies tend to have denser breasts, which may preclude the visualization of breast cancer, and MRI can be better. So, in high risk women, MRI has now also become standard of care for screening. Till a few years ago, it was only X-ray mammography, be it 2D or 3D, but now MRI can also be used for screening. In the UK, how do they do it? And I'm saying this because there are different ways that screening is being done around the world. In UK, you have to consult your GP, who refers you to a hospital high-risk clinic where genetic counseling is done, followed by genetic testing, and then X-ray or MRI mammography is done based on your particular risk profile. In India, we start at 30 years with an annual mammography, but we do know that an MRI is better, and hence one can do an annual MR mammogram. Now, you would have heard of two-dimensional MR mammography, which is how it has been till about 6-7 years ago, and then 3D mammography or digital breast tomosynthesis, which actually started about 7 years ago. The 3D mammography, or DBT as it's called, it creates synthetic 2D and it has a lot of 3D images. 3D is better and is especially useful for dense breasts. Since you're able to get thin slices of breast tissue, you're able to see abnormality much better, especially in dense breasts. And this improves detection of early breast cancer by nearly 25% and decreases the number of false positive callback cases by roughly about 15%. So in essence, a 3D mammography is better than 2D mammography, especially in ladies who have dense breasts, and is able to improve detection by about 25% and is able to reduce those who've undergone a 2D mammography and then coming back because something has been seen, you want to do something more, and reduces those numbers also. So the lady doesn't need to come back twice to the mammography clinic. Like I said, it has been approved for all women undergoing a standard mammogram. So 3D mammography, which initially was reserved for those where on 2D you found something which was equivocal or abnormal, this now has been approved for all women undergoing a standard mammogram in both screening and diagnostic setting. The radiation dose, and this was a question which is very important, since 2D and 3D images are created from the same acquisition, the synthetic 2D plus 3D radiation dose is very similar to that of a standard 2D digital mammogram. So even on the radiation dose, it is not that first you will do a 2D and then do a 3D. We can actually generate 2D images from 3D data, and hence the radiation dose is nearly similar and is not a cause for concern even in the screening setting. Now, what is the role of ultrasound in screening? Ultrasound, as you know, is omnipresent, it's available everywhere. The machines are there in all hospitals, diagnostic centers, and actually, in our country, it is the radiologist who is doing the ultrasound, and this has a very, very important role as an adjunct in screening, in both screening and diagnostic mammogram, in equivocal or positive findings. So you do a X-ray mammography and you say that I'm not sure. There does seem to be some abnormality, but I am not sure. Now, because this is a screening examination, one has to look at the mammogram with very high index of clinical suspicion. You don't want to miss a cancer in a lady who's actually taken the trouble to come and get screened for it. And so this is where ultrasound can be a very important adjunct to the X-ray mammogram. It has an important role in differentiating benign from malignant lesion. It has a very, very important role for guiding biopsies where you find some abnormality, and also in those who may be undergoing surgery for wire and marker placement. Because many times what we are able to see on an X-ray mammogram or on an ultrasound or on MR mammogram may not be visible at all to the surgeon when they are doing surgery. It may be such a small lesion. So that's where on ultrasound guidance, we put in a marker, which is a round little metallic thing, or put in a guide wire within the cancer so that the surgeon can actually know where exactly it is and be able to remove the cancer. It is also the first modality of choice in young women, and especially in those with dense breasts. Ultrasound can be very, very important as an adjunct, and in those below 30 years of age can be the initial modality. Now, on 3D tomosynthesis in the last 2-3 years, we are also doing contrast enhanced digital mammography, which shows a lot of good promise. It's excellent again for women with dense breasts. It is as accurate in the initial papers as MR mammography. It has lower false positives, and of course, there's no claustrophobia, even though the data on this is limited. However, this has a great promise in the future. Now, what about mammography in lactating women and those who had breast augmentation surgery? And there are, especially for breast augmentation, there are a fair number of ladies who undergo this. Now, These ladies may undergo screening mammography depending on clinical context and underlying risk of breast cancer. Breastfeeding or pumping immediately prior to the examination in those who are lactating women may help minimize any effect of lactation on mammographic density, and an annual screening mammography can be done in those with breast augmentation. And here too, 3D tomosynthesis is highly advantageous. So, in both categories of women, uh, uh, even during lactation or following breast augmentation, X ray mammography, screening mammography can be very well performed. Now, a word about diagnostic mammography. Age is no bar for a diagnostic X ray mammography. Now we say, and I've said this, that we start screening at 40 years of age. In average risk women, we start screening X-ray mammography at 30 years in those at high risk. But is that the cutoff? Will we never do an X-ray mammography below 30 years of age? No. In case a woman feels a lump, then age is no bar. Even if she is 20 years of age, you can very well do an X-ray mammography. However, targeted ultrasound is preferred as the first modality in patients below this age due to the excellent sensitivity. So even though we may still do X-ray mammography below 30 years of age, even if you feel a breast lump, we do a targeted X-ray ultrasound for that lesion because it's highly sensitive. X-ray, MRI, and FNAC may then be done as needed depending on the clinical context. So below 30 years, do first ultrasound, and if needed, age is no bar to doing an X-ray mammography. Now, women under 30 years, like I said, with focal breast signs or symptoms, the incidence of malignancy is very low, about 0.4%, slightly higher in our country. And targeted ultrasound, like I said, is the modality of choice with almost 100% sensitivity and negative predictive value. We may use MRI or X-ray, like I said, in select cases. Now, a question that is often asked to us is, should screening be stopped at 69, 70 years of age, as is done in many parts of the world where actually the patient is not paying and it's either the insurance company or the government that pays? Now, it is said that cost effectiveness of screening in those above 70 years of age has been questioned. So it is not said that you will not pick up a malignancy, but they say that for the number of malignancies that are picked up in ladies above 70 years of age in screening, it may not be worth the money spent in picking up those. However, there is no age limit which has been set in the latest American College of Radiology recommendations, and an annual mammography can be continued as long as age expectancy is 5 to 7 years still. You continue mammography annually for screening, and comorbid conditions that may be present in a patient, heart disease, stroke, all of these do not limit mammography. Now, who are the patients for which the American College of Radiology recommends annual screening breast MRI as a supplement to mammography? These patients include women with more than or equal to 20% lifetime risk of breast cancer. Again, like I said, beginning at 30 years of age, women with personal history of breast cancer and dense breast, women diagnosed with breast cancer under age of 50, and women with a known BRCA mutation. In all of these, annual screening using MRI as a supplement can be performed as per these guidelines. Now, we hear a lot about artificial intelligence. We've heard about the use of artificial intelligence in thermomammography. Can AI be a second reader in breast cancer screening? Yes, this has come in very, very well, and it is seen that sometimes when a radiologist may miss a breast cancer, artificial intelligence algorithms as a second reader can be very useful, and this is coming quickly into day-to-day clinical practice. So AI, even for X-ray mammography, is now being used in many parts of the world. Now, a word about breast MRI, the last 3-4 minutes, currently is the most sensitive technique for breast cancer detection with a negative predictive value of 98%. So when we say it's normal, we are correct 98% of the time. It has high sensitivity, 95 to 100% compared to mammography. So when in most instances we would pick up a malignancy, however small, if it is there, it may not obviate the need for biopsy, but can reduce the rate of negative biopsies. And this is how the images look like. And we also inject contrast in these cases. And you can see this lesion here, which is picking up contrast. And this really helps. So by and large, when we say MR mammography, it is MR mammography where contrast will be injected near the latter part of the examination. And here again, you can see this lesion here, a breast cancer, which is also seen on the plain MRI mammography. Again, another case showing two lesions in the same breast, and these multicentric malignancies can be present, and of course you're able to define the lesion very well. And we have certain kinds of curves which we look at, and a rapid uptake and a rapid downslope is what is seen in the classical malignancy. In the end, PET-CT, and PET-CT is actually not used to diagnose breast cancer, but is used in those cases where breast cancer has been diagnosed to actually see the extent of spread in the body, or when one sees that there is a malignancy somewhere in the body, and one is, say, in the liver, you have disease which is spread from somewhere else, then it can be a very useful adjunct where you don't know where the primary cancer is, to be able to pick it up, like in this case where a biopsy from the liver had shown presence of metastasis, and this arrow shows you a pickup of an unsuspected breast malignancy. And this is a 41-year-old left breast lump since 2 months. FNAC showed ductal carcinoma, and ultrasound and all that was done, didn't show much. But on the PET-CT, and this is a whole body examination that is always done, where you're able to see the liver lesions and you're able to see the breast malignancy, which is a multicentric malignancy, seen very well. Again, the same you can see. So, in conclusion, I like to say that screening mammography is very, very important after self-breast examination, and followed maybe in the years to come, in the months to come, by thermomammography, leading up to 2D or 3D X-ray mammography, ultrasound, MRI, and PET-CT, as the case may be. But screening is the initial step which picks up malignancy, and really we know that when malignancy is picked up in stage 1 or 2, it leads to a cure, whereas in stage 3 and 4, it's an uphill struggle. There is a lot of morbidity, there's high mortality, apart from the expense that is involved, and the emotional distress that not only the patient but the family has to go through. Thank you very much, Geeta, for giving me this opportunity. Sorry for the slides, the problem that happened, and over to you. Thank you very
Thank
much.
you. Thank you so much, sir, for that elaborate view about an experienced view about all the different modalities that are traditionally available for women. Does anyone have a question to ask, sir? So while people think about it, sir, maybe you talked about breast MRI, and you were one of the first ones to bring breast MRI to India. What were the kind of challenges you faced when because whenever you are talking about a new modality coming in, there's always people who are using traditional modalities saying, yeah, we'll be able to detect it, you don't need the new test. So what are the kind of sort of challenges you faced long ago in trying to make
See,
breast
we
MRI?
started Geeta MRI in 1991, and
Okay.
at that time there were just 5 or 6 machines in the country. Early '92 is when we really got started, and just to put things in context, All India Institute in Delhi got its MRI in 1994. So that's how it was. And we got a second MRI in 1997, and that's when MR mammography actually had started. And we got a breast coil, and you have to believe me, it cost 25 lakhs just the breast coil.
Okay,
And
okay.
from 1997 to about 2003, 2004, we didn't even do 25 cases. I mean, there was so much resistance or maybe lack of education. And it's only in 2004, 2005 that MR mammography came into its own. And now, of course, it's part and parcel. So you very rightly said, when there's anything new that comes in,
Yeah,
there is that initial reluctance. I would not say resistance, it is reluctance, because everyone is used to a certain way of working,
yeah,
and it does take time, it does take patience, it does take a lot of cajoling and education to bring it into mainstream day-to-day clinical practice.
absolutely, sir. Because of that, so many people can actually detect if mammography misses or because of dense breast. Today, they're able to go to a breast MRI. Absolutely. Kudos to you for doing that. In terms of your own, in Mahajan imaging, of course, you built it from scratch for now a couple of decades, I believe. Do you see most women coming in with symptoms, like after a clinical symptom, or do you really see people using it?
I think till maybe 5, 6, 7 years ago, it would be mostly we would be doing a diagnostic mammogram. Someone has felt a breast lump, or there's pain, or there's some reason. Screening, there were those who were well educated and they would come in for screening, but the number was few. Even today, even though because of education, because of availability of ready material, the numbers are increasing. So screening mammography is increasing, but yet, if we look at, and these are multi-crore machines that we have, most of the time the machine is still lying free.
Yeah,
So I think the reason is that there is really no structured screening program that
absolutely.
exists in our country. And if that were to exist, and if that were to happen, I think, especially in the urban areas where the risk of getting breast cancer is nearly twice that in the rural areas, and possibly when we look at a hall of 100 women, several of them are going to get breast cancer. I
Yeah.
think they would be amenable to coming in,
Yes.
provided there is a systematic approach. uh, uh, you know we in the private sector try in our own way, but I think this is a very important area where there is government focus. It's not as if they don't want to do this, but I think systems have to be put in place so that annually or once in 2 years, these ladies do come in. More important for those at higher risk.
Absolutely. So today, I think government says clinical based examination is the standard. We are happy to say that in many of the states, they have started using thermolytics. So that way, at least we can get more women who are likely to have an abnormality to these hospitals where they have idle machines, right? So, and also make them detect and diagnose it much earlier. There's one question, Mr. Madhav Kulkarni. Do you want, okay, maybe I'll read it out if you want to speak.
Please.
Say how to differentiate benign versus malignant in ultrasound breast, he says.
That's a very good question, and ultrasound breast does help in that. There are two ways. One is the texture of the outline of the lesion itself. Generally, malignant lesions are irregular. Their outline is irregular, and also we do Doppler examination, and there is increased vascularity within these lesions. We also do what is called elastography, on ultrasound. Mostly cancer is firm, is denser than normal breast tissue, and so the elasticity gets reduced. And this is also something which we make use of. However, having said that, would you ask me that as a radiologist, doc, are you so sure that now I come back next year without doing anything else? I don't think anyone would take that risk. If there is even the slightest suspicion that it may be malignant or the lesion is equivocal, generally a biopsy would be done under ultrasound guidance. So all these techniques, even the MRI, which is the most is the best at tissue characterization and differentiating benign from malignant, even there we would not categorically be able to say that this is definitely benign, so you can leave it. What we do in certain cases is do a short interval follow-up.
Yeah.
So you've done an ultrasound, you do an ultrasound again after 6 weeks or 12 weeks, generally 12 weeks, and see what is happening, or else. And also depends to some degree on the physician's approach, on the surgeon's approach, the patient's own preference, which also comes into being. So that is why I say when it's a diagnostic mammogram, then what to do is your physician interacting with you and then giving you the data based on which you are also able to, so that you don't feel that this is just an unnecessary biopsy that's being done. After all, a biopsy is an invasive investigation. And this is one criticism of MR mammography, where they say that it tends to overdiagnose because it's so very sensitive. But in the high risk category, I think overdiagnosing is not wrong.
He's not wrong. In fact, that leads to our next topic on vacuum assisted biopsy. But there is one last question, probably it's for me. Can thermolytics be used for all aged women? Thank you for that question and allowing me to talk about it. Yes, we say it can be used from 18 to 80. As Sir mentioned, it actually measures the temperature variations on the chest. And we analyze using AI. And in fact, in our data set, it was a symptomatic lady, but 17-year-old has also been diagnosed with malignancy. Obvious screening to be positive, and then biopsy was used for malignancy diagnosis. But yeah, we have found many 20 to 30-year-olds, who are suspicious of malignancy, sent them to an ultrasound with a target that is automatically marked by AI, and then biopsy. Ultrasound guided biopsy has confirmed. So yes, it can be used for both dense breast, fatty breast, and any age group at this point in time. but it does not replace any of the tests that Dr. Harsh Mahajan mentioned today. It is an additional test, can be used outside the hospital as well as inside. Thank you very much, Dr. Mahajan, sir. This was a real pleasure to hear from your own words about the different techniques and wonderful Q&A as well. Once again, thank you so much for your time. Really, really appreciate you.
All the very best.
Thank you so much, sir. Thank you. Thank you. Once again, thanking Professor Mahajan, sir. We move on to the next awaited topic on vacuum-assisted biopsy. There was a question about benign versus malignant. Do we need to do biopsy even for benign cases? If so, what are those cases? How easy or difficult it is? So we wanted to sort of, simplify the whole process for you, and none other than Dr. Bhavna Dev, who is an expert in multiple women's imaging techniques, is here to share some knowledge snippets. She's going to dumb down her talk so that all of us can understand. I heard her talk in IRIA, addressing many of the upcoming breast imaging experts, and I was really, really impressed, and I requested her to be on this forum to educate all of the sort of general population as well. Dr. Bhavna Dev is a professor at Sri Ramachandra Institute of Higher Education and Research, Chennai. She's a lead radiologist leading the breast imaging and intervention department. She holds an MBBS degree from Amritsar Guru Nanak University, an MD in radiology from Sri Ramachandra Hospital, DNB radiology, and she's trained in radiofrequency ablation techniques in Italy, fellowship from musculoskeletal MRI in San Diego, California, and also breast imaging and interventions fellowship in Miami. The highlight of her resume is she has over 60 publications, amazing research inclination, in addition to amazing service to her patients. And she has just over 20 years of teaching experience in different universities. And she's also very active in professional bodies like IRIA. She's a treasurer in Tamil Nadu state chapter, as well as she was a joint secretary in BC Breast Imaging in India from 2017 to 2019 until 2021 as well. Thank you so much for agreeing to share your knowledge in a common words, ma'am. Really, really appreciate. Request you to kindly share your slides and educate us on vacuum-assisted biopsy. Dr. Bhavna Dev, ma'am.
Share
Green color, share.
share screen.
Yes. Whole screen, you can say first one. Full screen, you can select and then say share. Yeah. Perfect. You can see your desktop. And yeah. Yes, thank you.
Yeah. So thank you, Geeta ji, for this opportunity. And as we all heard, Harsh Mahajan sir, about how important it is and how important it is to find early breast cancer. We are all I'm very passionate about breast cancer, okay, to find as early as possible. So now, as sir has already told, we have techniques which can find the cancer, which is even 2 to 3 millimeter in size. So imagine if we find cancer of that size, it is fully curable. So I actually, whoever is listening here, I request all of you to have a screening done. Okay, as sir has already told, screening means when you don't have any symptoms. It's just that, you are going for your regular checkup. You include screening mammography in your, regular master health checkups. And so that, if God forbidden there is something, we can find it. So we have been talking about cancer, and it's a Cancer World Day. But today I thought I'll speak about something which is, which is just come up in a bigger way. And now in India, we have this available in multiple places. This is something called vacuum-assisted biopsies. So we've been talking about, sir was telling that when there is a mass, okay, somebody asked the question whether how will you find out about the benign and malignant. So when we are as a radiologist, we have different signs, okay, on ultrasound and mammogram as well as on MRI, which tells us that, you know, it might be a malignant mass. But for it to be sure, we have to do a biopsy. So when it comes to breast masses, and what all we can do to them is we can do, you know, a core needle biopsy, which will confirm whether that is a malignant or a benign mass, whether that's a cancer or not cancer mass. That is thing. Another thing which we can do is something called vacuum assisted biopsies, and so on and so forth. So these are the things which we do to diagnose it, whether it is a cancer or not a cancer. But there are certain things which we can treat also, you know, if it's either a breast cancer or it is a benign mass. See, all masses found in women are not cancers. First of all, we should think, okay, we should take that home message back home also. We should not think, agar if I have a mass in my breast, it's going to be a cancer. It's not that. Okay, because fairly in younger women, there is something called, all of you would have heard, fibroadenoma, which is very, very common. And now these fibroadenomas, if we prove it, first of all, we have, when you have gone to a doctor, that doctor will say it might be a fibroadenoma or it might not be a fibroadenoma. But in case, if you like to do a treatment which is done under radiology, done under seeing, you know, under ultrasound mostly, we have to prove it first to be a benign mass. Okay, it has to be non-cancerous. For example, the fibroadenomas being the most common, we can treat now. After, when we are doing this treatment, we look into the ultrasound machine and we start treating this. And these can be treated by some things like vacuum assisted biopsies, which is our topic today. Then there is something else called radiofrequency, microwave ablation, cryoablation, laser ablation, and high intensity focused ultrasound. So these are all the available techniques which can actually, without surgery, you can treat your benign masses. So whenever the most common, as sir was telling, whenever you see the mass on ultrasound, which is most common, you know, every street has an ultrasound. So if you see that, you know, you can see that mass very well on ultrasound. So you can get that mass treated under ultrasound or biopsied under ultrasound. If you do not see it under ultrasound, then whichever, like see, it was seen more better on mammography. So you will get it treated under mammography, or if it is seen only on MR, then you can get it treated under MRI. So coming to our main topic, basically it's a very simple, as the name says, vacuum. So, you know, there is a machine which creates a vacuum, okay, into the needle. Okay, and then I'll show you this video, it will become easy. So there is a machine outside which creates a vacuum in this part of the needle. Once the vacuum is created, the part of the tumor or the part of the breast comes into this needle trough, and the cutter comes. This is a cutter coming up. It cuts that part of the tissue and finally it takes it back. You can see this yellow tissue going back. And again, the machine will create a vacuum. Again, this part of the breast or the tumor will come into this trough of the needle. The cutter will come. See, this cutter will come and it will cut that tissue, and you can see this tissue going back now to the chamber. So this is how it cuts the tissue. And this is a needle which is like a little thicker than you can say the normal biopsy needles. Actually, if you have to see, it will be like a you know, the cut on your, I will show you in the end that how the cut is, how small it is. Okay, but just to tell, you know, smallest bindi which size available, that is the cut, okay, for a general population. So we don't cut at all, it's that smaller cut which goes in. So this is how it is. When we go inside the breast, when we look into the ultrasound, we position our needle. If this is your tumor, okay, benign tumor, this is a fibroadenoma, which is not cancerous. So the needle is usually placed, you know, below the tumor. And as I was showing you by the video, the tumor comes into this area. The cutter comes. See, you can see the cutter is coming here. It cuts the tissue and then it takes it back. So this we do multiple times, like, you know, depending upon the size of the tumor, we have to do it 7 times, 8 times, or sometimes 20 times if the tumor is up to 4 centimeters or so. So the machines, this is just, to make my presentation little flowery. So these are the machines which we have for this. So this can be done under ultrasound. All of you would have seen this machine, and this is a mammogram machine. And this is a vacuum machine, which I was telling you. The needle is attached to this vacuum machine. I'll tell you how it is. So this is a vacuum machine, and these are the vacuum equipment, which is actually in this part of the machine. And this is the needle which we connect this to the machine. Okay, this is the heart of the needle. Onto this, we fix this, and the needle looks like this. You can see this. This is how much the needle is, which will go inside your breast. So finally, and these are the things which are extra attachments if we are doing it under X-ray mammogram. And this is how it is done under X-ray mammogram. The patient sits on a very comfortable chair, and we, put the needle within the breast. Looking at that, you can see it is so small. Okay, it is such a small, thin cut is given, and the needle is inserted into that area, and the tumor will be sucked out. So basically, if in your report, what happens is where all we can use vacuum assisted biopsies, as I told you, mostly, we will be using it in fibroadenomas, as we are dealing with the benign thing today. So if you find benign things, fibroadenomas, a lot of young girls and even, young women we see a lot of fibroadenomas between 20 to 40 years of age. So if your report has told you have got a biopsy done and it tells it is a fibroadenoma, we can get this treatment done, which is totally non-surgical. So this case is she's a 31-year-old. She's very anxious to conceive, and she had come to our department of gynecology, and they were investigating her for infertility. So most of the hospitals now, this is a protocol. When the patient comes for the infertility treatment, they usually send the patient for breast ultrasound. If she's less than 40 or above 40, they send for mammogram. So when she was sent to us, we found that there are small fibroadenomas. Okay, there were small benign lumps in her both the breasts, right and left. Okay, though they were very small, as you can see, it was only around 1.5 centimeter each. So we could have just followed them up. But the patient was very, very anxious. Patient said, no, I have read it somewhere that these can become big and this can become cancerous. Okay, a lot of, Google auntie gives us a lot of wrong information. So she had heard this, and she was in IT. So she was both husband and wife were very, very curious. They said, we want to start our treatment, but we don't want this in our breast. So we said, okay, we can do, I opted them this, vacuum assisted biopsy treatment. So before doing the treatment, we did a biopsy. As you can see, there's a biopsy needle which is inside in her left breast mass and a right breast mass. So biopsy proved it to be a fibroadenoma on both the sides. So after that, we started on ultrasound machine. You can see it's a simple setup. There's an ultrasound machine. This is how the patient is, and it is, the most important thing is it is done under local anesthesia. There is no need of, general anesthesia and all. We just numb that part of the breast through which we are going to give the needle. And it is done, looking at the ultrasound machine. And this is the machine which you can see, which is a vacuum machine. So you can hear the voice. See, you can actually see on the whatever is going on within the body, it's depicted outside also. That now the vacuum is created. The cutter is coming, you can see here. And it is cutting the tissue, and it will take it out. So see, now this has become blue, means it is just cut it, and now it will go back. So whatever we are doing inside, it is depicted on this machine. So it's, very accurate and a nice method, so that we are, we can absolutely do it without any difficulty under local anesthesia. And patient is usually very, very comfortable. They don't have any pain. And this is how it actually, when we are doing inside, this is how it is. See, the needle is there, and you can see that, how her tumor is being cut and get it into the machine outside. So after, what we do is, now we have taken out, both the tumors, both the fibroadenomas from her both breasts. Now what we do is, we follow nowadays world standards, because, I'm very proud to say in India today, we have everything. Okay, so it's not that, we are lacking behind from any other country or anything. So we have this marker clips. So these marker clips are put in that area from where you have taken out that fibroadenoma. So why is this put? This is put because then it becomes an indication that this is the area from where we took out the tumor. So she goes anywhere in the world, they take her X-ray or they take her ultrasound, they know that from here the mass was taken out and this is the place where something was done. Also, sometimes this is not for this fibroadenoma, but in case in some of the patients, if the tumor is very small, 2 to 3 millimeter or up to less than 1 centimeter, let's say, so some of the oncosurgeons, they ask us to do vacuum assisted, because that way we can take out the entire tissue and give it to pathology for proper analysis. So in those cases also we put this clip so that the surgeon has to go back to this area and take it out, because we have already taken out the entire tumor, so he won't know where was the mass. So that's where we leave this clip so that it helps the surgeon to reach that area and allow it to be cut. So this is another patient, she had a lump which was she had a small breast, and this is a lump which was actually started seeing out, she could feel it and she could feel that there is a lumpy breast on that, and she was getting married in 3 months. Lot of patients we get like that, lot of young girls. Okay, she's 22-year-old and she's been seeing this month for the past 6 months. So you can see this is also a round mass and all that. So the first step when we see it, we know on ultrasound, we have signs, as sir was telling in the previous lecture, this is not an irregular mass. This is very well-defined mass. So we know it that, it is not going to be a cancer. Most likely it's not going to be a cancer. But still we have to have a confirmation that this is not a cancer, which is done by doing a biopsy. So we did a biopsy and we found that it is also a fibroadenoma. So after that, we have again, as I was showing you in the first slide, that we place the needle below the mass, and then what happens is the machine cuts it, as you can see it again, it cuts it by part and part and takes it out. So after that, we have again put a clip. So what happens is there will be a little bit of, very little. Okay, this is about 1 cc of, which is a blood around that clip. Okay, in some patients, it can happen like that. So, some people ask, will there be any bleeding, anything? There can be a bleeding, but it is very, 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 very uncommon. And usually after we finish this procedure, we give a compression to the patient, which is very important. On the where we have taken this out, about 10 minutes of compression we give, and we give cold fermentation. So most of the patients, they don't have any issues after that. Okay, maybe if you are you have a very white skin, sometimes that ecchymosis can happen. That also goes away within 1 or 2 weeks. So this is the clip which I was telling you, which is a must after doing a vacuum assisted excision. And you can see it that after the this is about 2 weeks after that, slowly everything is becoming, see, this tissue is becoming like a normal breast tissue. This is a normal breast tissue. So everything normalizes within 2 to 3 weeks. And this also, this marker clip won't be even, it can sometimes get submerged with the your breast parenchyma. Patient comes, you won't even know that you have done something there. So it's such a neat procedure. There's another lady. Okay, sometimes the older ladies, I thought I'll just show this case also, because sometimes older ladies, they come with the nipple discharge. They said that always also, since this is a general talk, I would like to emphasize on one point, that most of the ladies, they think if they have a pain, they have a cancer. Okay, which is very, very wrong notion. Breast cancer, 98% of the breast cancers is painless. Okay, if you have a lump which is painless, you should report immediately, because it is most likely a cancer. If you have pain, it is actually good that it might be due to the hormonal changes or some infection or some inflammation. But if you have a mass, please, and if it is not painful, it is a very, very dangerous thing. So please, spread this word among your friends, among your relatives, that if you have a mass and it is not painful, it is a dangerous mass, you should report immediately. You should do ultrasound or mammogram. Whatever is available at that point of time, you should do it and get it checked. Also, another second thing which patients think is, if you have a blood discharge from your nipple, only then it will be a cancer. It is not that. If you have a serous means if it's like a watery discharge, especially from one nipple, then also you should immediately report, because it could be an indication of a cancer. So these are the things which, as a layman, we think, no, if it is a blood only, it will be dangerous. And if it is painful only, it will be dangerous. It's not so. So if in case, you have a watery discharge from one nipple, or you have a painless lump, please report immediately. So this lady came, with a serious discharge from the right nipple. No prior examination. So we did her mammogram, and we saw these kind of calcifications. So when we see these kind of calcifications, they, in our radiology perspective, they are looking like suspicious. Suspicious means they can be cancerous. Okay. So then what to do? The patient did not want to, obviously you can see, imagine it is actually, this is a zoomed view. Okay. But it was looking like this small. Okay. For this small a thing, you just can't chop off a full breast. Okay. And patients nowadays, nobody wants to lose their body part. So nowadays, everything is conservative. Breast conservative surgeries have become so common, and they are done so well in our country now. So for all that, we need a, proof that what it is. Because if it is not cancerous, then the treatment is different. If it is cancerous, then the treatment is different. But you need to prove it first that what it is. So we did a vacuum assisted biopsy for this patient. Okay. This is how the patient was placed and the needle was put in. And you can see after the biopsy, there are no calcifications. See, this is the place which has become like that. We have totally sucked that out, and you can see here, it's white parts. These are the calcifications. So this is how, immediately you can actually X-ray that specimen which has come into this tray, and you are sure that you have taken it out. And we sent it for histopathology. We sent it to be checked under pathology. It came out to be a benign disease. And this is how her clip looks. See, this is a very small, the clip is also like a small size, like a smaller than a bindi. Okay. So it is, this is a zoomed view. This is how you are confirmed that this is the area you have put a clip, and there is nothing in that area. You have taken out entire that calcifications which were looking like a cancerous. But fortunately for this lady, it was a benign calcification. So she's just on a regular follow-up. So now when we have done the procedure, we have taken it out. How the patient has so many questions, doctor, will it bleed again? Will it swell again? Will it do this? Will it do that? Okay, so to answer those things, first is when we take a sample out, I showed you that how the needle looks. So usually when the needle is cutting over in this part, the sample keeps collecting here, okay, in this trough. Okay, so we don't insert the needle out and in again and again. It's just the one time we have to insert, only the sample keeps coming out and keeps collecting here. So this is how the sample looks. Okay, these are the cuts which have been taken out, and then we put it in the jar and send it for histopathology. This is just for not for the common people, but this is how the samples look. Like one cut, once the cutter goes out, once it takes out this one part, then second time, third time, fourth time, like this, so and so forth. And this is what I was telling you. End of the procedure, we have only this. This is smaller than your bindi. So this is what is, the needle goes through this, and we take out the entire fibroadenoma. Up to 3.5, it is commonly taken out, but we have taken out up to 5 centimeters also, and patients have done very well. So what we do is, as I told you, as soon as we finish the procedure, we compress the patient so that there is no internal bleeding, nothing. Okay, we give some cold, ice pack we give, okay, so that patient does not feel any pain, and we just put some pressure bandage on the patient like this, simple. Okay, only instruction which is given to the patient is don't lift the heavy weights for a day or two. In a sense, like, some ladies will bucket of water or some clothes, you have to put it on the thing. Nowadays that's not common, but still, okay. So we tell them, you can do your routine, like, they can go back to their routine work, they can go home and cook, they can go home and serve the food, everything can be done, except that, just be cautious that, don't lift heavy bands. And this is how the bandage is put on them, and they are sent home. So this is these are the okay, this is, I'll show you the, so mainly, when we are doing this procedure, what happens is, it is very easy. It is done under local anesthesia. First thing is that. Second is, you can go back home the same day. Okay, it is quite not expensive, and it is very cost effective. You don't stay in the hospital, you don't get anesthesia, so and so forth, and there is no scar at all, which is very, very good thing. And sometimes you just get some discoloration, as I told you in the beginning. That is, your skin becomes blue when you get somewhere you get hurt and it gets blue. It will be like that, which will also become normal in sometimes. So this is one case which I'll show you. This is how this is a small
Tell me if you feel anything or pain, okay? Okay.
So I'm telling the patient if she feels anything. Patient is so comfortable. Patient does not feel anything. They will just feel this sound. Okay, and this is how it is cut. And finally, if the needle is placed properly and the patient is not moving, everything is going okay, within 5 to 10 minutes, you are done with the procedure. As you can see this.
Yeah, this is amazing.
And that's all. It's gone. The tumor is gone. So this is something new which we thought. Actually, Geeta ji told me when she heard me that we should tell the public that this is something which has newly come up, and we should be aware of it. See, finally the patient has to choose whether they want a surgery or they want a non-surgical treatment. So but there are certain things which are available in our country and we should be aware of that. Thank you so much.
Thank you very much, ma'am. As usual, this was an amazing talk, and I'm sure all of us here have benefited from this knowledge sharing that you've done. There are already multiple questions to you. I will read this out, and if there's people who have asked questions want to ask orally, they can unmute themselves. The first one is from Ayesha Nawaz. What's the advantage of vacuum-assisted biopsy over core needle biopsy?
Yeah, Aisha, these are two different things. Okay, when we are talking about the benign tumor, when we are doing a core biopsy, we do it just for the diagnosis. And for a benign tumors like fibroadenoma, we can take out the entire tumor using the vacuum machine. So that's the difference. So at biopsy, we just take out 2 or 3 cores and give it for sampling. Vacuum, we can take out the entire tissue, or much more like as I was telling you. See, when you are doing a fibroadenoma, what I showed you, you can take out the entire tumor. If it is something very small lesion like 1 centimeter, you think that core needle biopsy might miss it or something, you can again use a vacuum to take out the entire thing and give it for sampling.
What about true cut? Just
true cut and core biopsy are just synonyms, madam. So they are same. Core biopsy or true cut biopsy is the same.
Very nice. Another question from Himanshu. You mentioned about watery discharge, that is about nipple discharge. He's saying, what about pus discharge?
Yeah, see, the watery discharge is also, as I was telling you, it's a serous discharge. Pus is little thicker and it will be yellowish in color. Watery discharge is like a water. So that is the difference. Pus discharge is usually, most of the times it is from when you have an infection inside. Watery discharge is even some small tumors within the ducts, like, from where the milk is produced. If there is something there, some tumor or something, they can produce watery discharge.
So if somebody has nipple discharge, watery or pus or blood, they have to immediately go and do an ultrasound.
Yes, they should inform. So usually there will be a pus discharge or there'll be a milky discharge, like how you get on lactation. Then there'll be a white discharge, like a serous discharge, and or could be a blood. And sometimes, brownish and greenish discharge also can come, which is very common in young women, which is usually due to fibrocystic disease. But once you have these complaints, at least you should go to the doctor and get yourself checked. Very important, because, it could be an indication of something serious too.
Okay. There's this question from Dr. Collison. I suppose that you're faced with women with abnormalities on mammo for whom you do USG and vacuum-assisted biopsy. Some must come back as no malignancy. How do you handle these false positives? How many false positives are too many? He's asking.
Let me read this question once again.
Yes. Actually, vacuum-assisted biopsy, she's recommending for negative biopsy only, actually.
Yes, sir. So, Geeta madam is telling correct. So what happens is, once if the patient we have seen on ultrasound that it is a fibroadenoma, we think it's a fibroadenoma as a radiologist, and the patient wants to do a vacuum for that. So we need to do a biopsy for that. Biopsy will be proved as a benign, then only we will take it out. But as you are asking, if 1 or 2 patient, it is, come as a malignant something or not malignant, let's say it comes as a phylloid tumor. Okay. So that's why we keep the clip there. So that is the advantage of that clip. So the doctor, the surgeon can always go back and, do the excisional biopsy of that area.
All right.
In one of the
Okay,
earliest
yeah,
slides,
go ahead.
algorithm for diagnosis, there was mentioned about the cryoablation is a very, very good option for benign breast tumors. Okay, they have started doing it for very large malignant tumors also, because what it does is it shrinks the tumor. Okay, but we are talking about the benign tumors today. Cryoablation is proved now to be a treatment for benign fibroadenomas also. It is also, as the name says, it's basically the probe is inserted. As I told you, there is a vacuum created in this probe. Then when we put a needle inside, a cryo needle inside, a ice ball is formed. Okay. And the tumor is ablated. The fibroadenoma is ablated. But only thing is, we have it in India also at 2 places. Okay. One is at Coimbatore and one is at PGI Chandigarh. These are the 2 places where they have this cryoablation machines. Only disadvantage is a little expensive as of now, and it is not the cryo needle is little expensive. So, but if the patient can afford, yes, it can be done, and we have it available.
Talking about affordability, for the users here, vacuum assistant, just a range of how much it may cost, the VAB itself, ma'am?
VAB in some places, mostly it is between 40 to 60,000.
Okay.
Because the needles are, we cannot use the same needle. So needles are little expensive and they are all exported from out.
Okay. And also you're mentioning when we met in IRIA that in some countries, even small malignant tumors,
Yes.
are being treated with VAB, right?
Yes, even our oncosurgeons also, as I was telling you, if the tumor is less than 1 centimeter, so he does not want that with the core biopsy, there should be a false negative result, as Dr. Collison was asking. So if we have given pathologist a good amount of tissue, then obviously they will give us a better result. So for smaller lesions less than 1 centimeter, few of our oncosurgeons, they prefer to be VAB than to do a biopsy.
So Jyotsna has mentioned, amazing. What is the actual healing time inside the breast after the process? We generally say 1 to 2 months for lumpectomy.
For this, actually, the patient won't feel anything immediately. Actually, if they were feeling a lump, they'll feel little bit of hollowness. Okay, when they take out their pressure bandage, they'll see that the lump is gone because we have taken out the entire lump. And usually for my practice, I call patient after the next day because I want to see there is no hematoma, no bleeding. So I just do a regular ultrasound and see that everything is all right. And then I call them after 1 month. To see that everything is perfect. So usually I think I don't know how to answer this question, but I think it's there is no time. I think it depends upon different each patient, but let's say about because no patient has complained till date in my experience, that she had a pain or something like that. I think it just goes away immediately. That's all. And only that small scar which we give, small nick which we give to introduce a needle, that also heals within a week's time.
Yeah, well, this was amazing, especially giving the videos and the images, because even yesterday I met a patient who is biopsy, needle IAGA, is it painful? So of course there will be small pain, but because it's a local anesthesia and all of that, so I think it reduced the tension from many people. Even if there is a malignant lesion, this is a small procedure, you can get cured. The most important thing is detect it early so that it can be a very, very simple procedure to remove the lesions, whether malignant or benign as well. Thank you very much, Dr. Bhavna, ma'am. It's really, really a pleasure to have you. And this is going to be on our YouTube as well. And I hope many more people will view this and get educated on this. Thank you so much, ma'am. Really, really appreciate it.
So much. Thank you so much.
Thank you, ma'am. Thank you. We thank once again Dr. Bhavna, ma'am, and thanks for your interactive discussion here. And we move on to the third section of the webinar, which is a panel discussion among practitioners for screening programs on the ground. How can we take the screening to the rural areas, to the different corners of India, and identify women who need to be brought to the hospital for several of these procedures that were discussed today. So to run this panel discussion, we have our young colleague, Sania, who's going to be here. She's a bubbling new joining 3 months old in Niramai, and she handles the NGO segment. And so here off to you, Sania.
Thank you so much, Dr. Geeta, for this introduction, and welcome everyone. Thank you so much for joining. So before taking a lot of time, we'll just quickly head into the panel discussion. If Dr. Geeta can share your screen, okay, great. So I think we can start with introduction to our panelists for today. We are being joined by some esteemed people who've been working in the nonprofit space for decades. Firstly, I'd like to introduce Mritu Gupta to everybody. Who is the CEO of KPED. And Mritu is an accomplished public health professional with over 28 years of experience in the social impact space, with a decade-long focus on healthcare. She's a recognized leader within social government, multilateral agencies, and is committed to creating collaborative models of public-private partnerships for sustainable change. We all know, most of us know the work that KPED has been doing across the country to actually detect cervical cancer in the area of early detection, guiding patients, so on and so forth. And they've been a key component of just, taking cervical cancer to the communities and making sure that women get screened and the treatment that they need. And she's actually a force to reckon with, if I can say that. Thank you so much, Dr. Mritu, for joining us today. Next slide, please. Okay. We also have Tansi Nayak with us, who is the Vice President of ALVL Foundation. Tansi has been working in the public health space for over 12 years and has worked within the public and private space in India and across the world, and is engaged with stakeholders across different sections, including policymakers, CEOs, industry leaders, clinicians, so on and so forth. She's also contributed a lot to the advocacy and policy space in India and has contributed to areas such as universal health coverage, Ayushman Bharat, health infrastructure, public-private partnerships, health financing, so on and so forth. Thank you so much, Tansi, for joining us, and we're looking forward to your insights for the panel discussion. The third panelist for today is Dr. Suranjeen, who's joined us from Chopiego. And so I hope I'm pronouncing the organization's name correctly. Dr. Suranjit has been working in the public health space for over 30 years. He's the Director for Strategy and Partnerships at Chopiego, India, and has worked in the areas of maternal and child health, adolescent health, immunization, digital health, primary health systems, and disease surveillance. He's also led a campaign called Jashna for better nutrition outcomes for people on ground. And thank you so much, Dr. Suranjeen, for joining us today. Awesome. I will just stop here, yeah. And
yeah, over to you all. Wonderful to have you all on this panel. Over to you, Sania, again.
Okay, great. So we'll just dive quickly into the first question that we have for everybody. And after the introductions, I think we'd love to hear more about your work on ground in terms of cancer screening programs. How's your work been like? How's the response on cancer screening programs from the communities you've engaged with? Something more about your experience from ground with the organizations that you worked with. And if we can start with Tansi on this.
So good afternoon, everybody. Thanks a lot for joining in today. Thank you, Niramai, for giving us this platform. World Cancer Day is probably the best day to talk about all this. So Sania, to answer your question, ALVL Foundation is a relatively very new organization. We are just 4-year-old in the system. But so ALVL Foundation is actually the family foundation of Dr. Arvind Lal and Dr. Vandana Lal, who are the owners and promoters of Dr. Lal Path Labs. So both of them are in not really in retirement phase, but they're looking at things beyond the business now. So that's how the organization was formed. We started the discussion about 5 years back, and we registered and started everything about 4 years back. So when we were talking about what is it that we all are equally passionate about, one common theme came into existence, and that was primary healthcare. And that was coincidentally a very opportune time for us because the government, after a very long period of time, the government radically changed how primary healthcare is being viewed in India. So with the announcement of the health and wellness centers under Ayushman Bharat, and it was decided that 1.5 lakh such centers would be created. So we thought that this is a great platform for us to, plug in only the gaps that are currently existing in the HWCs, especially given the context that it is only the government that has a last mile delivery network across the country. There are several other not-for-profit partners who are working individually, and of course, they make great impact, but when it comes to scale, it's very difficult for one entity to reach a scale of about 1.5 lakh or 1.6 lakh primary health centers and covering a population of 1.4 billion people. And when we read about HWCs and we had a lot of discussion with government stakeholders here at the center, also in some of the key states, we understood that the idea behind HWCs was to move from traditionally RMNCH focus to a more comprehensive primary healthcare. And when we say a more comprehensive primary healthcare, the first agenda was to include NCDs, which are now responsible for more than 65% of deaths in the country. And if you see, cancers are a major group within the NCDs. But when we went on the ground, we actually saw that anyway, we were just talking about three cancers, oral, breast, and cervical. And even in those three cancers, at a primary healthcare level, we were not doing enough. So with that in the background, also it took us a lot of time to fix the basic infrastructural and other gaps. But now, as a country, we have about 1.5 lakh CHOs, community health officers, who are a completely new cadre of healthcare workers, frontline healthcare workers. And we thought that they can be a great platform to, add these new services. Like if you traditionally talk to ASHA workers and ANMs, who are our first port of call for the villagers in terms of health, they would not immediately talk about non-communicable diseases, even diseases like diabetes or hypertension. Leave apart NCDs, which are leave apart cancers, which are way more complex. Also, when you say diabetes or hypertension, it is very easy to at least do the first round of screening. That is not the case with cancer. You need people who are trained, who are well aware themselves, to go out into the community and also raise awareness about cancer. So that's how we are currently working in this space. We are restricted only to primary healthcare, but having said that, we recently launched a program with Niramai, where we are, for the first time in Almora district in Uttarakhand, we are targeting to do about 1,000 screenings. We started last month. We are doing a screening program for women. So we have combined cervical cancer screening and breast cancer screening. And this is the first time that these people were actually hearing about something like this. And so far we have been getting a great response, and we still have 2 more weeks in the first pilot. But happy to be a part of this panel and take on the questions that Sanya or the other speakers may have.
Thank you so much, Tansi. That's really helpful. Dr. Suranjit, can we hear from you about your work on ground in terms of cancer screening programs, and how has your experience been?
Thanks, Sanya. And I'll take up on what Tansi mentioned. As Tansi did mention about the health and wellness centers and the primary healthcare program, JPIGO is the official partner for 14 states in India to help establish, the primary healthcare program. So we've been with these states for the last 7 years, right from, getting these community health officers selected, trained, and deputed and placed within these health and wellness centers. And so, as Tanya mentioned, Tansi mentioned, these are the places where actually the screening takes place for women's cancers. And so we've been, there trying to see how best they can actually get to screen. But see, even after the government had a very, robust program in paper and also adequate funds, what we're seeing is hardly 2 to 3% of people across India have been screened for these cancers. And even in the best of states, like we talk about Tamil Nadu or we talk about Pondicherry or Andhra Pradesh, what we're seeing is it's never crossed more than 10% of the population. And that's a little bit worrying. Not a little bit worrying, quite worrying. What exactly is hampering these screening programs? So we've been actually creating models in 2-3 states. In Odisha, we've done in Jharkhand and in UP, where we've been actually trying to see what are the processes that need to be tweaked to ensure that we actually are able to do population screening, both for breast cancer, cervical cancer in particular, and oral cancers. So that's what we've been doing. In UP, we worked in Lucknow with SGPGI. In Ranchi, Jharkhand, we've been working with the Ranchi Institute of Medical Science, and the same in Odisha. So that's been our experience, and in trying to move the needle for cancer screening in India.
Thank you so much, Dr. Sudanjit. I think just taking from there in terms of the work being done on ground, Dr. Mridu, if you can also elaborate on what KPIT does, but also what is the kind of response that KPIT has been receiving on ground in terms of just accessing all these programs and just coming for the screening, so on and so forth. You're on mute, Madhu.
Yeah, okay. Now I can unmute. Sorry, I wasn't able to do that. Thank you, Sanya, for this, and lovely to meet all of you and to hear from you. I loved the conversation we had earlier with Dr. Bhavna. So lots to learn here today. Happy to be here. So yes, going by what the other panelists said, when you work in public health, it makes no sense to work in silos and to work on your own and create parallel systems. So all of us are working with the government, because strengthening the government processes and bringing the screening or bringing prevention down to a primary healthcare level is what is really needed if we want to make any kind of significant change. And that's the area we work in. But we have seen that you could, strengthen the processes, you can train the doctors, you can get all of that, but you cannot bring community to screening. And that's a gap that needs to be bridged. So we hear a lot of people who say that we go and create awareness, but we've realized just creating awareness in the villages also does not bring women. What you really need to do, and we have been experimenting with it. In fact, in Gurgaon, we have created a district model for elimination of cervical cancer. That's the area we looked at. We worked with American Cancer Society. And we have now created an implementation toolkit that's just being finalized, and it will be available for free use of any organization or government who would like to develop that at district level. So we've built the system about working at district level with villages to build trust first. So you take the time to build trust, be seated in that village, work with the panchayat and the pradhan and the asha workers and all of them, bring the men into the conversation. Till the men don't get involved, the women don't come for screening. So she has to know that it's all okay. She needs to know what's going to be the next step. They have very simple issues, like if I come for screening, kuch niklega to khana kaun banayega? Who will look after my kids? Who will do my daily work? How many days will I miss of work? These are very practical issues in the villages. And when we design our plans or our workflow, we don't take into account these little things that are their issues. So it takes a while. Sometimes, like when we were in UP, they were a farming community. So they have different timings when they will come to be screened or they will be willing to work with us. When we were in Gurgaon, they were actually domestic health, most of them. So they wouldn't come during the day because they won't lose a dihadi to come to be screened or to come with us for further diagnosis. So one of the most important things we have found is building this trust in community. So making community center focused always, it works from there. So we could work with the government. The government has a standard model that needs to be fitted in everywhere, but you have to tailor it to the location you are, to the village you are, to where it is. That's where we come in. The processes can be done, the training we get done through NICPR. So all of that is government-based, it can be done. But tailoring the community to the screening is where it requires a little bit of effort, and we try and, build that conversation and create communication material and do all of that. And that, I think, is, if you can call it success, that is the success of being able to do community intervention programs.
Thanks so much, Madhu. That's so telling. In fact, the common challenges that people face every day, especially on the ground level, we don't even think about that while we're actually sitting and looking at cancer in our small little, spaces that we're in. So that's really important. But just, going back a little bit from there, okay, we'll get the people for screening, and that's where, your IC material will come in. That's where the community trust will come in, building public trust, so on and so forth. But just taking a step back, cancer still across India, people look at it as the C word, it's not even spoken about. In fact, in my family, I lost both my grandparents to cancer, and my mom, dad are just like, don't talk about it, So it's still, there's such a big taboo around it. So screening is still, it's the next step after people are more aware about the disease. So, we know that there's some cancers which are preventable, treatable, and, the panelists and the speakers before this spoke about how if diagnosed early, it's treatable. So what is your take on that? How can we raise more awareness among the general public on cancer? And what can we do to just break the stigma around the disease to get people to screening? Yeah, over to you all. Whoever wants to go first.
So because I've been speaking, so I'm in the flow, sorry. So I'll just take this first. So, we all talk about this, that there's the stigma with the C word. In India, we have this concept, ki bura mat bolo, kuch bura ho jayega. So don't even talk about something terrible. And we say that and we sit back. What is being done? It's not like there's any program to get over with the stigma. It's not like we're really doing anything about killing the stigma. The only way it will go is by talking about it. I mean, it's like going out there and doing it. Studies say that 1 in 10 people will have cancer by 2030. It's about time we normalize talking about cancer prevention. When we go into a village, we always say that we are here, hum cancer prevention ke liye aaye hain, So when you know that I've come to protect you from cancer, they are more okay to talk about it, right? Yes, coming to screening becomes that if it is positive, then what will happen? Then I have cancer, So that takes a little bit of education to get. But if you're telling them that cancer can be prevented and we are here to tell you about how to prevent cancer, there is curiosity. They do come forward. Till the time we don't normalize talking about cancer and we don't go in there and talk about cancer, there's nobody else coming to do it. Who else do you think is going to walk into a peri-urban or a rural community to talk about cancer prevention and tell them that there's nothing to be worried about? Most cancers can be prevented or can be treated when caught early. And how to catch them early? What do you need to do? Where do you need to go for the next steps? If you simplify it, so I just want to tell you, there is this paper that Professor Banerjee had written that he won the Nobel Prize for on poverty. He talks about seeding information. And this was during demonetization. He was in Bihar and he wrote this paper and he spoke about seeding information to the less knowledgeable. So anybody who knows a little less about a particular topic, it creates panic, it creates chaos, there is superstition, there is fear. And if you can take the time to seed information, it takes away all of this area. So that I feel is the only way we will overcome stigmas. TB ka kitna stigma tha? I remember the black and white movies where, the protagonist had TB and it was the end of the world for them. He had to leave his love and his life and go away. Kitne movies? Now you have a DOTS clinic, everybody will go and ask for treatment when they need it, right? We've overcome that barrier, but we haven't done that for cancer. For cancer, we are all hesitant to talk about it. We all protect that stigma and whatever about it. But I feel advocates for cancer prevention or cancer should just talk about it. There's no other way we can break that stigma. But I'm happy to hear anybody else has any other scientific solution to it.
Nancy, do you want to add to that?
Yeah, so actually what Mridu said is absolutely correct. When you don't have the complete information, you have more stigma around something. And we have seen it first. What we did was initially when we asked the ASHA workers to, take
Nancy, I think your voice is breaking.
Cancer Awareness Month and everything, we saw that the response that we were getting was very meager. But we slightly changed strategies and we said that we will first of all screen the ASHA workers. The moment they were screened, they were super confident about going back to their villages, talking about it. Sunny, you mentioned that screening comes later and awareness is something that we really need to build on and then probably screen. But I have a slightly different take on this. If you do a lot of screenings, the stigma around that also goes down. I don't think you are ashamed of going and getting a random blood sugar test done, right? We do it in all our HWCs. ASHA workers do it in the communities these days. So if we have solutions where we are not asking people to come to the district hospital to get screened, if we can set up small camps everywhere in the HWCs without overriding the government system, if we don't want to do that, if we can do it as an extension of their ongoing initiatives, then also a lot of conversation around it starts. If we only in this case only, if we were not doing any screening and just talking about awareness, then there is no end point to it. And that's not anything new. So you need to close the loop. And that's the most important thing for especially the rural population. In the urban areas, we have access to so much of information. You Google everything. You can even go to a specialist just by finding out a specialist on Google. But in the villages, people are not that empowered to understand where they have to go for a screening, what is the next step that they have to do. So the community health workers here are very handy. If they have the right information, they can really, and if I go to one of the 100 odd villages that are in the catchment areas of our HWCs, nobody knows me. I would just be another person talking about cancer to them. But if the ASHA worker says something, it has a really different impact. I'm not sure if the same is the case with the urban areas, but in the rural areas, this is a model that really works, that if you spread awareness and you also give them something tangible. When, even with Niramai, when people go back with the small slip where they say that, okay, we got a normal screening test, and they compare each other's test and say that, okay, now we are in the clear at least for a year. And we have also heard people asking us that when is the next time you're going to do this camp in our area, and how frequently should we talk about it. So I think that's the kind of impact that will have if you make screening accessible at the community level, or at least at an HWC level.
That's so important. Thank you so much, Tansi. That's such a good perspective to have. Also, the fact that you said that screening actually goes hand in hand with awareness generation, and the fact that we can get ASHA workers to do it first to build that trust. Really important points. Dr. Suranjit, if you want to add to that.
Yeah, definitely. I also see Dr. Collison's hand up. I have two things to say, but Dr. Collison, you want to come in and then I can add.
No, I think he has a question. You can continue. You're on mute.
Sure, I'll go ahead.
Yeah, please go ahead.
Yeah. So, see, I think what Mridu and Tansi said are important, and awareness for screening may be present. But what we want to understand is, what is the quality of that awareness, right? Do people know? Do they just have a very fuzzy idea that some screening has to be done? Do they have an idea of what are the methods they can use for screening? Do they know the timing for screening? And so we've been talking to a lot of women, even educated, even women within my own family and within my own sphere of influence. What I'm seeing is that it's extremely fuzzy, this information. So then I'm asking, when it's out there, with just a Google search or with just something, why is it so fuzzy still? So probably it is the consistency of our messaging, consistency of who we believe are our influencers. Like, for example, every pediatrician would talk about immunization, would ask as soon as you get into a clinic and say, have you immunized your child? Did you get all your doses? Consistency, right? We tell exactly the same thing to every child. When it comes to breast cancer screening, even if a doctor walks into a hospital, what I'm seeing is my own colleagues, my own peers don't even ask her, do you think, did you get screened? in the history, which is expected, right? In every history taking, you're supposed to ask this question. But we don't even get to ask it. And sometimes I wonder why my own peers, why our own doctors don't even stress this. And that's where I'm thinking that there has to be a campaign approach. There has to be a big thing. Even in the United States, when breast cancer was a big thing, until you had campaigns around pink ribbon, until you had walks, until you had all these, things around this that built it. Awareness as a measurable thing, did not penetrate society. And I think that's what we need now in the Indian society. We need some practitioners who can actually do something that is which really brings awareness down and actually measures it. And the reason I took this is when Mridu said maybe there's something scientific around campaigns that we need to look at. Yes, I think we need to be asking this question, and we need to be coming to understand how do we actually get this message and how do we get consistency in this message. I also want to touch on what Nancy said, and that's very important. Like, even in the public health system, what we're seeing is services are just not available. Forget accessible, they're just not available in most places. And that 10%, is just that, and it's inconsistently available. Talk about the few privileged people like us who can actually get into a private sector hospital. Again, is it available? I want to get a HPV DNA testing on somebody I know, but is it available in my town? Is it easily accessible for me? Is it something that I can just walk in and get? What are the, what is the thing for even getting breast cancer screening and things like that? And I think that's something, we need to equally be aware of and, see. And that's something, I was also talking to a friend of mine and saying, can we have a whole district, get a whole district, where we can talk about trying to cover both private sector and public sector, through a campaign, and see that at least, 20 to 30 or 40% of women can get screened in that district, trying to see and model something that can actually work. And so today we're just restricting ourselves to women's cancer, at least most of my panelists. But can we get at least 20 to 30 women, for women's cancer screen in a district, a small district, not a big urban district, but see and understand what does it mean to do that, or even in a small town to see what does it mean to actually get that to happen. That's topic.
Thank you. That's really helpful. Very insightful points. Consistent messaging is key. And we've learned that with COVID vaccine messaging also, where, the campaign was rolled out and successfully so. But so one thing that you touched upon that's really important is key barriers in screenings. So even when people want to get screened, there are several barriers in terms of just accessing screenings. Like you said, that you want to get tested, but will a test be available in your city? And I know Nitu also touched upon that earlier. So just delving deeper into that. So once somebody's convinced, they're aware that they want to get screened, what are the kind of barriers that you think communities face nowadays in terms of just accessing reliable screenings, especially in tier 2 cities, tier 3 cities, peri-urban, rural areas? Ritu, if you want to start with that.
Sure, Sanya. So multiple barriers, I would say. For one is that there's no clear pathway that is made. So even if somebody has heard or they know that they should be screened, where do they go? What is the first point? Who's going to give them that advice? And what happens after that? So that pathway, nowhere in 2-tier, 3-tier, not even in cities. There is no clear pathway that is made for this. And then, like Dr. Suranjin was saying, the doctor messaging is also different everywhere. So if we say, if you're perfectly hale and healthy, you need to go in for screening, that is screening. Don't wait for the symptoms. But if a woman goes in and says, I want to have a HPV DNA test done, the doctor will say, do you have any symptoms? And she says, no. Doctor says, why do you want to get it done then? You don't need it, right? The doctors have to have there needs to be some protocol. There needs to be some standardization of what is done. We were interviewing a caregiver in October for breast cancer month. She had lost her mother to breast cancer and her sister had breast cancer. She was going with the sister for radiation and all of that, but she had not been screened. She was 43 years old. So I asked her, have you been screened? She says, I don't have any symptoms. No, I haven't. So nobody told her that she is a high risk and she should be screened. Her mother and sister have both had breast cancer. So that's an opportunity that was missed. And doctors are so busy fighting fire, you know, they're so busy, their OPD is full. They don't take the time to go through that. So these are the points that we miss for a woman to be able to achieve it. We say in 1,000 women screened for cervical cancer who may be positive, only 10 actually finish the journey. So there are multiple areas. One is also financing. So the barriers to being screened and to completing your treatment plan, there are multiple. One is knowledge about it. One is the pathway to it. One is the support system. One is the funding. There are many, many barriers to getting to completing your treatment. So they fall off the grid at multiple points. And there have been studies. I mean, EY has done a study on this whole cancer journey and how women fall through and why, and they've come up with multiple barriers. So some of them are here, but I really feel the HCP area needs to be strengthened. The practitioners, the doctors, they need to be trained. They need to know, they need to have a standard protocol. And also, if I have a pain in my back or my stomach or my shoulder, I'm not going to go to an oncologist, right? I'm going to go to my local doctor, whoever my doctor is. They are the ones who have to understand what to recommend to the patient. My mother, I lost my mother to lung cancer, but for 7 months, she was treated for TB. And it's very common, you know, lung cancer being misdiagnosed as TB is very common, but you have to understand that that same X-ray on which she was being treated for TB, she finally went to hospital for a bad case of diarrhea and dehydration. And the doctor in that hospital looked at her X-ray and said, ye to TB nahi hai. Fresh X-ray karao. And by the evening, he had said, get a biopsy done. So he read the same X-ray and said, this is not TB, on which he was being treated for the last 7 months. So there are a number of barriers that come into it, but I really believe that strengthening the primary health providers, that is an area that we should really look at. That would be the first step to easy access and to screening.
Absolutely. I think such good points. In fact, you know what you mentioned about losing your mother to breast cancer. Sorry for that. But, you know, the same thing happened when I mentioned that I lost my grandparents to cancer. So my grandmother had breast cancer and the exact same thing happened. They treated her for TB for 2 weeks. And it was much later they found out it was actually cancer. So exactly, strengthening, just from first-hand experiences, strengthening the front line that we have in terms of primary care, that's really important. Tansi, do you want to add to that?
I would also look at the lens of financing, which Mridu mentioned. If you see the national program for NCDs, a new comprehensive set of guidelines have recently come up, but we did an analysis some time back for the older version. And to screen for 5 common parameters, which was random blood sugar, hypertension, oral cancer examination, just a visual inspection with acetic acid for cervical cancer, which is a very archaic method. We totally don't promote it anymore, and clinical breast examination. So for these 5, for lack of a better word, these 5 tests, 85 rupees was kind of the allocation per capita, which is grossly inadequate. So at a primary healthcare level, even if you bring in the best of the innovations, and like you have thermal scanning for breast cancers, you also have imaging for oral cancer that are at an early stage detection. For cervical cancer, we have tried to bring down the cost of an RT-PCR for HPV. That has also happened, but in spite of all that, you can't bring it down to 85 or 86 rupees per capita. So we really need to look at the kind of allocation, and there are several studies that have been published, and one of the statistics is that because of NCDs, we lose about 2% of GDP every year. So that's a huge cost that we already pay. So we somewhere need to do a rationalization exercise that maybe some bit of more funding has to go into it. And when I say funding, of course, very little of our population is covered in insurance. Plus, insurance doesn't cover these kind of tests. So more of public funding, public health expenditure on screenings at a primary healthcare level would actually ultimately be a cost saving exercise, because to treat these patients under whether it is ABPMJ, whether it is privately paid out of pocket by these people, it will be very expensive to treat cancer. So we need to do, there's a lot of need of advocacy, and maybe organizations like Japaigo, which are already working with so many governments, can look into it. I don't know the latest figures, but this was approximately 3 years back that we did this analysis. So we need to fundamentally look at what we are financing, because unless you, and most of the innovations are by startups, so they'll not be able to do it on their own. And when it is needed, we have done this. If you look at COVID testing, we start in the private sector, it started at about 4,500 rupees per test. But I think nowadays it is about 399. It happened because, of course, there was a huge demand. The cost of doing those tests went down, and accordingly, the private sector decided that we can now charge less for the same. Why can't we do similar things for cancers? Somebody has to take that initiative, and government being the largest provider, it has to come from their end. They have to start the conversation, and I'm sure even for TB, the private sector has done a lot in terms of diagnostics and making it actually a successful notifiable disease. So can we look at something on the similar lines for cancer, because it is almost as important as TB?
Absolutely, absolutely. In fact, the recent budget, and I know Dr. Geeta has also mentioned this on chat, the recent budget has some allocation to cervical cancer specifically and the vaccination, and now they're focusing on rolling out the cervical cancer vaccines across India. So,
yeah, we did hear the announcement, but I did not see any line item in the finer details where a budget has been allocated as such. But of course, it was great to hear about it.
yeah, okay. Thanks, Nancy. Dr. Suvanjan, do you want to add to that?
Yes. So I think a lot of points have been raised. Apart from I think some of the barriers already been talked about, like awareness, like finance, like seeing there's adequate financing to back any public health programming, like Nancy mentioned. I think Vidhu also talked about the competencies of our providers to actually do screening. I'd like to touch about availability and competency again. But competency again of the health in the public health system, we are expecting CHOs and ANMs to actually do these screenings, and so competencies of these workers are very important. So recently with WHO, we had actually done a study to understand why screening has been abysmally low in these years. Apart from like breast cancer screening doesn't even need any extra resources. It's supposed to be done, just with. But what we saw was one of the major things was competencies, that just the CHOs and or ANMs did not feel that they were not that they didn't have the confidence to go ahead and what they call a breast cancer screening just by a breast examination, a clinical breast examination. And so that's something we've been also working on, trying to get skills labs in place at at these district levels where they can actually continuously practice their skills in doing clinical breast examination. So we have humanoid models with lumps within the models that they can identify and pick up. And I think that's some skills we need to do, because when the government ran the program, they just did one-day training and then expected them to, actually have the skills that are needed. And the same thing with cervical cancer screening. So for example, the VIA, visual inspection, using acetic acid, is something, apart from skills, requires a lot of extra equipment, and that's required to actually get this to be done. Supplies, a light, the being able to actually sterilize certain equipments and at least keep them clean. And what we see is that really all these don't come together, and that's one of the reasons why VIA doesn't take place. So actually getting all this in place is something that's critical. Again, and that's why it's hardly available, if not accessible, is what we're seeing. We've been actually advocating with the government to switch from VIA to HPV DNA screening. It's a bit costly, and it's quite costly rather than, but that's where we're actually working with multiple providers to see, how they could actually bring down costs, but it's not going to come down to the cost that Fancy said, but definitely, considerably less, and see how that can actually happen. And so we've been running some pilots where we've got some donor funding. We were trying to saturate, screening with using the HPV DNA test kits that, that can be used, and showing that it's a model that can be used. The next one that I want to highlight is, if I'm in the government system, if I want to do a walk-in test, that doesn't seem to be available. I have to only rely on my community health officer to provide these tests. So if I say walk into a district hospital or walk into a CHC and say, okay, can you screen me? They're lost. So there's nothing like a screening, and that's something we've been talking, and especially with Nirmai and other places. Can we at least have in our district hospitals and community health centers an ability to screen whenever a patient wants to walk in? Why should we actually just wait? Why should they be like if somebody's more aware, or somebody actually has a lump and feels that they need to come in, they should be able to walk in. We've also been looking at district hospitals, the medical officers within the district hospitals, to be actually able to do a clinical breast examination and pick up lumps, and then actually do a biopsy. What does it take for various district hospitals to be actually able to do this? So in the state of Odisha, what we have been trying to look at is, can we at least get 25% of these districts to be able to actually put together what we call a diagnostic program in place? So, so even if what we're seeing is, even if they're getting screened, most states, they have to be only referred to a medical college or to a regional cancer institute. The district hospital really does not have the ability to handle these patients. And so, we are like that. Our maturity of this program is really low within the public health system, and that's something, we need to be looking at. And as I told you, within the private sector, what we've been seeing, unfortunately, is that there is no standard practices. If I see if even in a small tier 2 city, if I see the number of surgeons doing breast cancer surgeries, and I know this is a live program, and I don't have data to back me up, I just got anecdotal instances. But if I see the number of, the huge number of breast cancer surgeries happening, but if I ask how many of them are, have followed the formal protocol of deciding, what it was. And just now we heard of Bhavna, there's a lot of, conservative surgeries, very good conservative surgeries that are happening. But what we're seeing is, no evidence-based thing for which surgery needs to take place and how it needs to take place. And that's something lacking, again, within our, fraternity here. And so how do we get these consistent messagings around treatment protocols is something that we need to be talking about.
Thanks, Dr. Surunji. That's really insightful. Just segueing from there, there was a lot of conversation before this on public-private partnerships, and I think you also mentioned that. In terms of just strengthening the health system because there's so much deficit in terms of resources, in terms of quality, so on and so forth. We know that along with public-private partnerships, there've been a lot of new technologies that have come in, AI for that matter, and just how we're integrating those kind of disruptive technologies in our programs on ground. So one thing that we feel is that we've seen in our work is that building trust in any new technology on ground is a little difficult, right? So, Tansi, if you can just talk more about how your experience been like with ALVL, just kind of navigating that experience of building trust within the community to actually roll out a new technological intervention for cancer screening.
Yeah. So honestly, Sanya, I've heard a lot about people saying that it's very difficult to introduce something in the rural setup. The awareness is very low. But when we were talking about the foundation, even before we started, we had one of our stakeholders who said that, the first thing that we need to do if we are planning to work in the rural areas, it's completely your choice. And if you want to do this, then we need to stop thinking of them as poor people who don't have access to anything, and you'll just treat them with whatever substandard things you have, which are just affordable. So if you stop thinking of the rural customer or the rural consumer as somebody who's not aware of things, I think a lot of our problems get solved there, because we have introduced a lot of new things when we entered the HWCs. And honestly, the uptake might be slow, but we have never seen a lot of resistance in uptake of any new technology. Like even with Niramai, when we started the screenings, of course, day 1, day 2 may be slow. But once people got their reports, once people got screened, they spread the word. And since then, we have had better responses. The second thing is about approaching the right stakeholders. When we went into Uttarakhand, we signed an MOU with the NHM Uttarakhand. And then we started talking to people down the line. But we understood that NHM, while they have signed the MOU and officially they are our partners, most of our work are done at a block level with the block program manager of NHM, not the NHM MD or the officer in charge for HWCs. So approaching the right stakeholders for introducing any new technology is probably a good thing to do. Like in the screening campaigns also, I have noticed this, and Sanya, you also have the data, you can cross-check it, that wherever the village pradhans are women, we have seen better responses there. Because our approach is, when we do a village camp, we are doing a mix of camps where we place the equipment like 3 days in a week in one of the HWCs, 3 days in the community level at any village in association with the CHO and ANMs there. Whenever the Pradhan is a woman, she tries and brings in more people. So she is the right stakeholder, of course, because if my team, of course, they know who we are now, but if my team goes and talks about cancer or getting screened, the response will be lower. But if they're one of their own, it's talking to them, plus she's a woman, then it is easier. So how we market the technology is one of the most important things in terms of how the uptake will be at a later stage. And in terms of resistance, again, if you see in many of our primary health centers and HWCs, the CHOs and even the medical officers are very young. So I don't think that it's very difficult to tell them that this is an AI-based technology or this is a digital health tool that will make your lives easier. So approaching the right stakeholders with the right messaging is what I think is critical in terms of introducing a new technology.
That's so helpful, yes. Especially in terms of just identifying the right person, and just especially like when women are at the top, like when they're leading, it's just the outcomes are different, and we've seen that. Okay, so with that, I think I will just request the audience members to drop in your questions in the chat box. We'll be taking them after this. Right now, we have one question from Dr. Collison, and we'll take that after this round. Dr. Suranjan, if you want to add to this about implementing new technologies at the ground level and the trust, building trust around them.
Yeah, thank you so much. And I think Dr. Collison's question is also around the same thing, and I'll try to comment. So building trust, and we work with multiple technology, and people are quite curious, or they're quite. I mean, they really don't have barriers to new technology as such. It just has to be available to them, and there's something's new. Unless there's some myth around it or something like that, people get worried. Like when the vaccines came out, there were a lot of myths, a lot of misconceptions around it. So as long as those myths and misconceptions don't come into play, usually people are quite keen to, to move towards any new technology. They have actually, what we have seen is there are no qualms at all. But what we have seen is adoption of new technology within the health staff has always been a challenge that we need to be working with, not so much as the people. And I think that's an important thing. How do we work with them? Because it's obviously asking them to get to know the new technology, get to understand it, learning, and actually getting to use it. So, but I guess that comes under, learning, and that's something in the medical field is always, it's a constant process, and we have enough practices to see how that moves. But saying this, technology itself is very important, and since we were looking at women's cancer screenings and roughly giving examples around breast cancer screenings and cervical cancer screenings, let me tell you the both of these screening programs that is at this moment being promoted within India for the public health system at least are dependent on the person doing it, and technology would actually make it something more possible where we can get better sensitivity and specificity for testing. For example, in breast cancer screening, if it has to do with thermolytics or with the mammogram, whatever we're talking, obviously then we are ruling out the clinician's ability to actually to discern it, because at this moment it's all discernment from within the clinicians. I'm talking even about the public health nurse there. The public health nurse's discernment to diagnose. Same thing with cervical cancer screening. If we probably use HPV DNA testing or also use an AI-based, cervical, now they have, things that can view a cervix after using VIA, and then use technology to take photographs of it and read it. Even that would improve the sensitivity and specificity of our screening program, and improve both compliance and actually people's trust within the system. Saying that digital technology also plays a huge role here. And what we're seeing is with telemedicine actually coming in a big way, I'm sure perhaps you must have heard of e-Sanjeevani and other things, that the public health system is actively working on. And I'm sure, these things would help. But the third most important thing that we need to be working on is this whole navigation piece. And again, that's where this whole data and apps that can help track patients, help provide reminders to patients, help actually help them navigate systems, and that the system does not lose them. I heard somebody, I think Nidhu was talking about 10 people, like less than 10 people actually complete the treatment journey. And that's because even if I have a manual way of looking at it, these things will fall through the cracks. So unless I have a digital system where these are continuously flagged and reminders set in, what we've seen is these people would continue to fall through the cracks. So we've got e-tumor boards, we've got so many, technologies that can come in that can help this process. And yes, we need to embrace technology as much as we can, so that's the only way we can leapfrog and stay.
Thanks, Dr. Suranjeen. And I hope that also answers Dr. Collison's question. Again,
if I may just, if I just may enter, okay, anyway, Dr. Suranjeen is like my classmate, so we go back like 25, 30 years. Tansi also I have met, not yet Mridu Gupta, but now all of you people in the public health, and I'm like a little bit newer into the public health, but there is the elephant in the room in trust in the government sector. Is that A&M of the correct caste? Are they actually doing the job? CB, are they doing the CB? VIA, are they doing the VIA? So that is where I think technology actually will triumph, especially in our countries where the education system is going to wait for everybody to be educated and aware. You're going to wait 50 years because you're putting this high-tech laptop. Laptops are available everywhere, including the village. You're putting on a laptop with the software, machine learning trained on previous. So the expert is there. And I believe that is the technology enabler. So look at that and digital. Look at the COVID experience. Everybody got the reports. Okay, you got SMSs. The government was informed who was COVID positive. So they sent people with remdesivir and all the tablets to the houses. Now, that can be replicated. But it actually requires a different thinking away from the A&Ms, ASHA workers. And that is what I think Nirmay has got right. Okay, so that is what they've got right, because we are putting a very, very highly, it's cost effective. Okay, the hardware and the software. It is cost effective and it's putting the expertise and is giving a reason for the people in the rural areas to trust the system, because it is not based on any person's individual assessment. So that's the question that I was asking. It's difficult to write in one line, but hopefully I just wanted to introduce to this public health forum that's the power, replicate, get the signal must be tied up to the government. Somebody then has to go to that's what Surendra was just talking, navigation. Okay, so once we give the signal, that's when the government needs to get activated to take that person for the follow-up test and for the diagnosis. So I just wanted to bring this perspective, and I hope I'll stop talking right now, but that's the power of thermalytics.
Thanks so much, Dr. Collison. That's really helpful. I know that we're also running out of time, so very quickly we'll just take Dr. Mridu's view on this, on just your experience of just leveraging new technologies on ground, and how's it been like in the public health space.
So I think the earlier panelists have touched on most of it, but the biggest problem in the public health sector is resources, right? So we don't have the manpower. Who's going to read the reports? Who's going to do the tests? So when you bring in things like this, we actually overcome the manpower shortage that we have. And also the tests that are currently being done are very subjective. So I know that gynecologists themselves shirk away from doing a VIA. They would prefer to do an HPV DNA because it is more, it's more definitive. A VIA is very subjective. One has to be really experienced to be able to see a VIA and say a VIA positive or not. It takes years of experience to be able to read it that correctly, and that's not there at the primary health center. So it takes away from that subjective response, and it gives you something that is, like I think Dr. Collison was saying, it is all machine learning, and it's more definitive, and there's more efficacy in that, and time. So definitely it is. And in the community, they don't know if it is a new technology or an old technology. If you bring something to them and you tell them this is what we are going to do, they see comfort level. So we've tried the self-sampling for cervical cancer also with them, as opposed to the HCP guided sampling. They have adopted that. We tried the EVA machine. It was a handheld colposcope. We tried that with in the communities. That was accepted very well. The barrier, like Dr. Suranjin was saying, is actually at the healthcare level. The government is not willing for you to bring in a new technology and use it. They need to have it vetted. And surely, I think it's perfectly valid to have any new technology vetted. There are so many in the market. How do you know which is better? So that due diligence is definitely required. There are other breast screening technologies that have come in, and other governments have been using them for a while, and then they've decided, oh, not good enough, we need to change. So we do lose time and effort when we do that. So that due diligence is very important. But even in the private sector, I was recently on a panel, and we had doctors from private healthcare, hospitals, and like Gangarams and the other larger hospitals in Delhi. And they were also saying that a mammogram is gold standard, and we shouldn't get involved in these new AI things that come in. We should stick to our gold standards. So it's not just in the public health sector, even in the private health, to bring in new technology will require real education of the healthcare providers and get them to understand it and to get some ease of using it for it to actually come in and be added to the screening modalities that exist. So while it has its positives, I think there is a bit of a journey for us to really integrate it into everything the way it is, the way we need it for a seamless growth. So in communities, I haven't seen that they have been very difficult in adopting anything new. So it depends on how you put it to them.
Yeah, I think that's also similar to what Tansi said earlier about just packaging it right and just not having the haves and have-nots kind of statements put out and treating everybody as equals. So yeah. Okay, so if nobody has any questions, we will be happy to wrap this panel up. I'll just wait for 30 seconds to see if anybody raises. Okay, Dr. Geeta has raised her hand.
Yes, yes. First of all, excellent panel insights here from different. I mean, I see that there's so much diversity in the panel also, in the, because Suranjin is from an international NGO doing this for a long, long time, and IBM Mrudu is of course dynamically started it, and Tansi more like a corporate offshoot of a foundation on how those things work, and it's great to get the insights. My question is more in terms of the scale that we are able to achieve at the screening camp level. Let's say if you do a camp or an initiative, let's say on a daily basis or a monthly basis, what kind of turnout that you see at a village level, like few hundreds in a day, few hundreds in a month? What kind of scale do you see today?
So for us, with one device and one technician, for breast cancer screening, we were able to do about 50 patients a day. And for cervical cancer, we were, of course, doing an RT-PCR HPV test. So it was just sample collection. So for breast cancer, we have, I think, maximum in one day, we have done 58 screenings. 62 were scheduled, but remote areas, there was some issue with the electricity. Some people dropped out. But I think we're able to reach the saturation level. And also, in these camps, you can't expect the entire village to come in on one day. And the fact is that you have to make it more of a permanent activity. So you do a rotation kind of a thing, and you come back to the same village after 6 months, and you will definitely see that the response rate is way better. So it one depends on the capacity of the machine or the technology that you are using. But I would say that you're able to achieve your day's efficiency easily when you actually go into the villages, because in the starting we were having this conversation that people are scared that they will lose a day's wage or they will have to take a day off to go get screened. So when you do it at a HWC or a PHC level, that might be a point of contention, but you go to the villages and they're more than happy to actually go get screened.
Okay, nice. Mrudu and Suranjin?
Yeah, so for us, Geeta, we do village screenings, but we do it with the PHC. We do it with the government.
Okay.
So first we do the training through NICPR, and we do that. And then for each camp that we have 1 day of awareness first. So we do the door-to-door mobilization. We speak to the village. We get a little bit of a health survey. We tell them there will be a screening the next day. So we do about 120 women on any particular day. And we do cervical, breast, and oral, all 3 cancers that they are screened for. So we do between 100 and 120. And we do up to 8 or 10 these days, because, you know, we have targets to meet for our donors. So currently we're doing almost 10 camps a month, but otherwise we average to about 8 camps a month with awareness days before them. So each camp, we need at least 3 days to do 1 screening camp. So that's how we build it. And we do about 100, 120 screenings in a day.
Very nice. That's pretty big. So indeed, I think you're
Yeah,
large.
our experience was, we wanted this to be totally owned and driven by the Health and Wellness Center. So I'll tell you, so in one of our modules where we worked in Jharkhand, what we said is we built it with the, like a human-centered design. We asked the workers to come together and plan it. So I think, and we said that, you know, the government wants you to screen 50% of the people within a year's time. So what did it mean? So what they came up with was a fixed day service. You know, they said, okay, we will decide Tuesdays or Wednesdays, you know, where we need to meet. And then one of the key things was that, you know, privacy was missing and things like that. So we had to get that all into place. And the second one was, again, telling people and getting them to come in. So they said that they would stick to 10, or some people wanted to stick to 10, some people wanted to stick to 20 per week. So, but we said, can the Ashas then make sure that these 10 or 20 people actually come in? So how would the Ashas actually create that list, talk to those women, get them to come in? You know, how would they actually meet them in person primarily? Basically listing and, you know, creating a list so that, you know, they could come in like a queuing system. And it did happen. Then we also had a kind of village meetings saying that we are going to start this. And so we created something like we used, you know, charts. So basically there are 5 things for breast cancer, like a lump, nipple discharge, anything. So these 5 key symptoms. We made it into like small posters, showed it to every woman and said, women with these should probably come first and book your appointments, you know, at the thing for 10. And then after that, everybody else also should come in whenever there's time. When we did this, and so these are things that were decided by the CHOs and ANMs themselves. And, you know, we just facilitated the whole exercise. And we did notice that we were actually able to increase anywhere between 20 to 80% screening within those villages. You know, certain villages did 20%, others, you know, really took off on 80%. But what we saw at the end of the day was these processes. This process, you know, we just call it process, you know, the same guidelines, the same thing, just that, you know, trying to fit these small management processes, you know, that we've learned in just management of how do we get this.
Thank you. I think all of these are very, very useful. And one last question, if I may, Sanya. I know we are like, so do you get the ground level government folks to involve in these activities? Or, for example, would you need additional technicians from your side to do this? Or would government folks be able to continue doing this? Both ways, one for mobilization and one for conducting the screening. So are the government folks involved at all in your activities? Maybe yes, no, yes, no.
Yes, for sure for us, because we work through the HWCs. For all our screening campaigns, the CMO,
mobilization.
Yes, the CMO signs off a letter, sends it out to the block people, and then everybody is mobilized. And I believe it is the same for the other 2 also, but
yeah, it's
Yeah,
for us
only
also.
for
The ASHA
mobilization.
workers, we do our mobilization, our awareness, our community health surveys and all with the ASHA workers. It's all part of the NCD program. The ASHA workers already have formats for this on how to mobilize them. And we, of course, train the the doctors at the primary health centers, the MOs, CMOs, the staff nurses, they are trained. And NICPR has a very good ecosystem where they train, they have an echo program. So they train the HCPs and then they follow up with them. So every Wednesday, there is an echo, 1 hour of the echo program where you can share your problems and they will solve them for you. And there is this peer learning that continues. So it's good for the MO. So yes, they are very much there and they are very much part of the whole system.
Yeah.
Yeah, same with us, because we want to take things to scale, so we don't want, so whatever we suggest, we try to suggest minimum external, investment.
Absolutely. I think for sustainable sort of screening programs, scalable as well as, large scale, persistent screening programs also, I think it's good to have the government involved. Thank you very much. I think it was an excellent panel, wonderful insights shared. Thank you, Sania, for wonderfully moderating it. I really appreciate all of your time. At short notice, you were able to come in. It was actually conceived within a week, and we had excellent speakers, including those we're seeing on the screen. Thank you very much. And I'll hand over to Dr. Collison for closing remarks on the whole program. Over to you, Dr. Collison.
Yeah, we obviously had a great 1.5 or 2 hours. Anyway, starts with Dr. Harsh Mahajan. Anyway, there's no way I can compliment him more than, I mean, he stands for himself, whatever his commercial success or his accolades, government awards are all secondary to the fact that he is a doctor interested in his patients, and his way of enhancing patient care is through imaging. So he evaluates everything very fast, and he gets the technology into India, and then he also collects all sorts of amazing images all the time, and he's showing it everywhere. So that was a very good start. And then, of course, to the future. The future is minimally invasive, and now it's also come into the field of breast diseases. Okay, so there was a time when we had to have an operation, a cut on the abdomen to remove a gallbladder. That's a thing of the past. So now it's a keyhole surgery. So that has also been so wonderfully exhibited by Dr. Bhavna Dev about what can be done with this vacuum-assisted biopsy. Then the challenge of cancer screening, be it cervical, breast, lung, head and neck. It's a challenge that, in my opinion, independently, India has to solve for itself, because we are the world leaders. So as Mrudu was saying, you go to a conference and somebody's talking about mammographic screening. There is no mammographic screening. Okay, so there is only 2,700 mammogram machines, and it's too expensive. There's no technicians. There's no radiologists. It's not the future, and that's reflected in the WHO. Now, is the future strengthening of CBE? I don't believe in that. I think it has reached its limit. Okay, so on another day, I can share with you of the literature that where CBE is stopped. Even training, even going about, whatever something new has to happen. And again, just because Mrudu mentioned we have had other breast devices and then the governments have used it, but those were not enhanced by machine learning and AI. That's the difference, Machine learning, AI, ECG, heart attack, promising, lung cancer, promising, diabetic retinopathy, promising. Everything is very promising, but it's only promising is limited by utilization. So we really require from the public health community more awareness. It's not just awareness of the society radiologists. It's also awareness that bringing the expertise on a laptop to the villagers is very acceptable. They love this. And that is what is going to really drive people to get screened. So that's the last thought that I would just I'll leave with you with a thank you for all your participation, and hope we can do this again. But again, it's not startup, it's not new tech, it's the power of the machine learning algorithm pre-trained on previously diagnosed case. So you're going to get a very, very good output acceptable to the villagers, and we need to integrate that with the existing system. So thank you all.
Thank you very much, Dr. Collison. That was very compelling. Hopefully, that will also help more adoption of thermalytics-like technologies. Thanks once again for all the participants, the audience, speakers, and closing remarks, and panel moderator, Sanya, as well. Thank you. It was a wonderful session. Please watch it again on our Facebook and YouTube whenever you get time, if you want to sort of recall the points. Thank you once again. Have a great evening. Thank you. Really appreciate your Sunday time denoting. Thank you. Bye-bye.